Hello, viewers of Dental TV. I'm Dr. Jung Young-eun, MC of Case Discussion. So I succeed Dr. Kim Tae-eun, who MC'd the previous case discussion. She did an excellent job and I tried to match up with her. This is my first time to play this role, but we try to address the questions or issues raised by the viewers so that we can be of help in your clinical practice. We have 3 guests today. Hello, nice to meet you. Now let's get started with the case discussion. We asked our viewers to write to us if they have any issues or questions. We'll talk about lower posterior GBR cases today. The first case, 35 female patient, no systemic disease, and 7 months ago, the teeth in the lower left posterior were extracted. And the question is, as the bone is very thin, what is a good way to do bone grafting here? So here is the intraoral x-ray. The bone width is knife edge, very thin. On the CT, it also looks like so. So you're looking at the case, what do you think? Let me go first. In this patient, she's a female in the 30s. But I see a lot of old patients who have worn partial denture for a long time. So many of them are in the 50s and 60s. As you can see, edentulous areas bilaterally and bone width is knife edge. If you open the flap, the base is broad and the top portion is knife edge. I frequently use a lot of GBR. Implants are placed at positions that we want. Even though the defect is dehiscence, we measure the desired volume and the height, and we determine whether it will be submerged or not. If the dehiscence is brought horizontally and vertically, it is submerged. If the defect can accommodate the simultaneous approach, we place the implants simultaneously. Simply with GBR, the knife edge case was addressed. As for the knife edge bone width in the lower posterior region, depending on the alveolar ridge condition, the treatment can be different. First, in this condition, the horizontal bone is deficient, but if we have enough vertical bone, the treatment can be different. If the horizontal bone is deficient, but the vertical available bone is sufficient, the most frequently used conventional GBR can be used. However, if certain conditions are met, other approaches can be used as well. So I brought my patient's case here. In quadrant 3, 1, 2, 3, 4, actually implants are needed. Let me show you how I treated quadrant 3. The horizontal width is very small, but the distance to the mandibular canal is long enough, so I used another option. On the CT at number 5, you can see knife edge bone width. Number 6 has some horizontal bone width. Like this, if certain conditions are met, thin cortical bone, broad ridge base, and sufficient bone marrow, and vertical height is sufficient, ridge split can be used for the treatment. However, in this case, to address the knife edge bone width, horizontal bone width should be at least 4 millimeters. Alveoloplasty is performed. In this case, Osstem asset kit is used for the ridge split. Horizontal osteotomy is performed. Using the asset kit, split is performed and implant fixtures are placed. The advantage of this approach is that additional graft or membrane is not needed and implants are all within the bone, ensuring a certain degree of stability for a long time. Due to housing effect, without graft, bone can be regenerated. That's an advantage. So simply the surgery was performed. CT, post-op CT, post-op 4 months. As you can see, prostheses were completed. At that time, you can see bone is maintained without being resorbed. So when horizontal width is insufficient in the posterior region, ridge split can be used as one of the options. Dr. Jung, that was a very good case from Dr. Son and Dr. Yang as well. Knife edge. Many people have knife edge bone in the lower posterior region. And three-dimensional vertical resorption can be observed, but knife edge cases are more frequent. How can we treat the knife edge case when we place implants? In summary, if the residual crest width is 4 millimeters or more, as Dr. Son mentioned, ridge splitting can be done simultaneously with the implant placement. If the bone width is less than 4 millimeters, first, knife edge bone can be addressed with the GBR or black bone graft. After bone is regenerated, placing implants later is a good option. As Dr. Son said, knife edge bone at the mandibular posterior region, these are the conditions to do ridge splitting. The bone width should be 4 millimeters at minimum, and CT should be checked. If the cortical bone is thin and cancellous bone should be enough inside, then we can do the ridge splitting. In the mandible, when we do the ridge splitting, we need to check the bone quality using CBCT. That's the key point. However, if you look at the case under discussion, the bone width is not very good for the ridge splitting. So if you look at the case under discussion, the coronal bone is ground in general. That leads to lower vestibular sulcus, which means poor prognosis. Therefore, I prefer to do GBR. With whatever approach, I do bone grafting, and later I do the implant placement. About 20 years ago, for the knife edge bone, I did a lot of block bone graft. This is a case 20 years ago, knife edge bone width. Block bone is taken from the ramus for the block bone grafting. After 5 months, the bone situation is very good, facilitating implant placement. Block bone graft at the knife edge bone has very good prognosis. Many dentists are not comfortable in taking the block bone. It requires instruments. When you take the block bone from ramus, it can damage nerve, and the patient can complain pain and swelling in the area where the bone is taken, so people are hesitant to use it. Recently, I use Builder to do the ridge augmentation, simple diagrams. Builder from Osstem is used to do the bone grafting. After 4 or 5 months, implants are placed. Additional bone grafting is not needed, and the non-resorbable membrane does not need to be used, so GBR can be made simple. An example, this is very similar to the case under discussion. The posterior teeth in the quadrant 3 are missing, and the ridge is knife edge. The same is also observed in CT, especially in the crestal area inside. There's hardly any cancellous bone. In that case, the split would not work very well. So GBR should be done, and implants will placed later. GBR in the lower posterior region, lingual and buccal periosteal incision very important, and bone grafting. Smart builder is positioned. If necessary, resorbable membrane can cover the site. In this bone grafting procedure, which is not very difficult to do, about 5 months have passed, and implants can be easily placed. Final prosthesis, especially in the lower posterior region, to do successful GBR, most importantly, soft tissue should be dissected properly. So we need to dissect, and inside the buccal side, we need to be careful not to damage the mental nerve. The vertical incision should be made at least 5 millimeters away from the nerve, and the periosteal incision should be made sufficiently so that soft tissue can be extended. On the lingual side as well, over the mid-hydromus, soft tissue is incised all the way and sutured. Horizontal matrix and interrupted suture need to be properly used to prevent opening, leading to a good outcome. I want to ask a question to Dr. Yang. In your case, implants were placed in knife edge ridge and the GBR was done. The knife edge ridge is not a housing defect, it is a one wall defect, so we need to be very careful. Do you have any specific know-how for that? That's a very good question. The frequently encountering dehiscence defect, if you look at the shape of the defect after implants are placed, here they are clearly exposed. I didn't show you GBR steps. We want to change the defect to do simultaneous placement. In that case, I definitely use autogenous bone, and autogenous bone can be covering the site first, and over it, xenograft can be layered, but these days the trend is to mix the different materials together, and there are papers available for mixing graft materials. So layered versus mixing the materials, that's not important. What is important is we need to use autogenous bone here. And many people overlook this thing. You used Builder. I don't use it. I use resorbable membrane. This is an old case, so non-resorbable membrane was used here, but these days resorbable membrane is used more. So the cervical area of the implants, even though we do over grafting, they go down. They don't remain where we want them to be. So we need to be careful in building up the bone to get the desired outcome. So I use autogenous bone. So it is good to use autogenous bone, but it is quickly resorbed. So this is not a housing defect and they quickly disappear. Therefore, xenograft is mixed together, then we can slow the resorption and I think we can have a good outcome. Do you agree? I agree with you. I also used xenograft with autogenous bone here in this case too. So regarding the first case, you explain the advices, tips. So ridge splitting and the bone grafting can be done, and autogenous bone or smart builder, os builder can be used. Tips for suturing and bone buildup have been shared by our guest doctors, and thank you very much. Let's go to the second question. 53 male, mental or remarkable things are not there. 5 months ago, number 46 is extracted. Bilateral bone loss is severe in the lower posteriors. Can I place implants or do I need to do GBR? Together on the panorama X-ray, it looks like 46 and 37 are extracted. Bone height is as high as the root of adjacent teeth, very low. 5 months ago, they were extracted, so bone has matured. In the clinical picture, the buccolingual bone and the vertical bone is deficient. Mesial tilting is also observed at 47. So you're looking at the case. What do you think? Dr. Chung Jong-chul first. In this case, 5 months ago, teeth were extracted. Soft tissue is healed enough. No problem there. On the panorama, the vertical bone is severely resorbed. In general, if you place short implants or implants on the bone level, it may damage the inferior alveolar nerve. So in my view, this happens frequently. The perio patient shows this type of phenomenon after extraction. There are two types of treatment. First, a GBR can be done to grow bone sufficiently to place implants, or GBR can be done simultaneously with implant placement, or short implants can be placed at the bone level. That is not a very good idea, though. Bone level would not be aligned, and in terms of prosthesis, it's not favorable. In the long run, complications can happen. So when I received this case under discussion, I tried to find a similar case of mine. At number 46, severe perio disease is observed, so it is extracted and it led to the bone defect. We used to do block bone grafting by taking the block bone like this to do the bone grafting. This is not very difficult. It is fixed and the bone grafting is done. We wait for about 5 months. It is healed and then implants are placed. That is what we used to do in the past. With the block bone grafting, As I explained in the first case, the patient can experience some discomfort after the bone grafting and implants are placed later. It lengthens the treatment period. So I do grafting and implant placement together. Graft is done and implant is placed and the prosthesis is delivered. It is pretty well maintained. This is a recent patient. Number 36 is missing when the patient came to the office. This is very similar to the case under discussion, so I use a simultaneous approach using a smart builder. The key point of using the smart builder is we need to check the biotype. If it is very thin or heavy smoker, that can be opened. So here you can see the defect. Intraoral picture, the alveolar bone is vertically depressed quite seriously. So bone is placed at a desired position above the bone. We need to be very careful not to damage the inferior alveolar nerve. So during surgery, I check in the middle. Using the smart builder, GBR is done. At the same time, type 3 smart builder is used. Buccal or lingual size. The smart builder doesn't cover the buccal or lingual size. Smart builder should play the role of a tent, and the resorbable membrane is placed on top of it. Next, soft tissue is sutured. When suturing, the soft tissue should be released sufficiently in the lingual and buccal side using the periosteal incision, and that needs to be sutured. I wait for over 6 months. So when I do large amount of bone grafting, at least I wait for 5 months or 6 months, and then I do the secondary surgery. The bone is very well formed, as you can see during the second surgery. This is after the second surgery, after final prosthesis, CT after final prosthesis. The bone is very well formed and maintained. In this case, I prefer to use as much as possible using a smart builder. GBR is done together with implant placement simultaneously. Thank you very much. Dr. Son Young-hui, do you have anything to add? Vertically, the vertical deficient reach is always challenging for us. I use very similar approach to Dr. Jung's approach. And I have a question for Dr. Jung. When you use a smart builder, what kind of graft material do you prefer? Personally, vertical augmentation. As I have a practice, I don't really use autogenous bone. Allograft is used as a base and xenograft is used on top of it, a sandwich technique. These days, I don't really use autogenous bone a lot. Dr. Yang said there's advantage of using autogenous bone. It is definitely so. In that case, I use allograft and xenograft together. There are advantages and disadvantages, and depending on each dentist situation, the choice can be made. Allograft has more bone generation capability. Xenograft, on the other hand, is not resorbed pretty quickly. So when you do huge amount of vertical augmentation, if you use just the allograft, in the long run, the grafted material would be resorbed. Therefore, in that case, I use xenograft and allograft. If I may give you a tip, vertical positioning is most challenging, as you said before. The grafted material on top can be remodeled. Therefore, for vertical positioning, I believe it should be positioned a little bit lower than usual. That can be a helpful tip for you. Thank you, Dr. Yang. I agree to some of it, and I don't for some other parts. In this patient, as Dr. Zhang said, in a perio patient, the treatment is very challenging. In this case, we can see the similar situation. The patient came and the tooth is extracted first, and then the treatment began. This is similar to the case under discussion. Now here, the location is 47 instead of 46. At the initial visit, teeth were extracted. After 3 months, I couldn't see bone growing. The perio situation is really serious in this patient, so the distal tooth is also extracted, and we decided to do grafting there. These days, alveolar ridge preservation technique is available, but at that time, it was not widely used. As you said before, simultaneous approach is used now, but at that time, staged approach was used primarily. So I follow that. You talked about autogenous bone and xenograft. I tried to use autogenous bone. On the basis of xenograft, autogenous bone is used together. From the wisdom tooth, autogenous bone was harvested, and GBR is done in a normal way. The patient left and came back later. Implants were planned, but after a long time, it came back in 2010. If you look at the picture, the GBR site, autogenous bone, and the xenograft was used, and the alveolar ridge is pretty well formed. 5 or 6 years passed, so it is fully healed. If you look at the composition of inside and the form, the graft was very successful, and I made a video out of it. The rich form is very well maintained, and the height and width of the bone is enough to place implants in the mandible. As we talked about the placement positions, for the comfort of a patient, simultaneous approach is better, but placement positioning is rather challenging. As you said, you can place a little bit deeper than usual, but here the bone is available, so it is helpful to make the site favorable like this before placing the implants. So I use GBR a lot using autogenous bone and xenograft. Today, I use a simultaneous approach quite a lot, though. In this case of Dr. Yang, so in your case, a vertical resorption is severe, but still there is one wall left, so you could do the grafting and could get very good outcome, but If you look at the case under discussion, if you do grafting and place implants, grafting would be more challenging than Dr. Yang's case. Yes, in my case, as you saw before, there was one wall remaining. The wall was high. Here both lingual and buccal walls are very low, so this is much more challenging. If you do not use a block bone, resorbable or non-resorbable membrane can be used, but it can be much more challenging, right? When there is a height, today we can use a tool like OSBuilder 3 to make the height, but if there was no wall, I would have used a tent pole to get the height and then do the GBR. So regarding the second case, you said GBR is done before implant placement. Do you have anything else to add? In the past, about 20 years ago, we used the block bone graft a lot. And we invited many speakers from abroad, and we also had block bone seminars. And I also published a book on that subject. I attempted to do a lot of block bone grafting, and the result was pretty good. And it's the autogenous bone, as Dr. Yang loves. It has very good outcome. But people are afraid of harvesting the block bone, so for various reasons, frequency of using block bone has decreased. Recently, I tend to use a smart builder, which works like a tent to maintain the space, and the resorbable or non-resorbable membrane can be used over it. And if you get more confident in suturing, in both cases under discussion, a good outcome can be achieved. Thank you very much. Today we talked about the GBR in lower posterior regions. So I would like to thank all the guest doctors for participating in the discussion. I hope this is helpful to your treatment journey. Thank you very much. Thank you.
교수님, 원장님 감사드립니다.
고맙습니다.
고생하셨습니다.
고생하셨습니다.
고생하셨습니다.